afternoon, everyone. I am Dr. VERHAEGEN, endocrinologist in the Antwerp University Hospital. And we first thank the organizers for giving us the opportunity to talk a little bit about the transition in our center and the problems and opportunities that we have with it. So we are talking about transition, and before we continue, first a little moment on what the definition is of transition, seen as the purposeful and planned movement of adolescents and young adults with chronic diseases and medical conditions from child-centered to adult-oriented healthcare systems. And for us, that means that the goal should be an effective communication so that people gain from childhood to independent self-care, and that they can make their decisions on their own, optimizing their quality of life, and so that they can take every future potential with their chronic disease. Ideally, this healthcare transition should be uninterrupted so that care is continuously given, is comprehensive, and of course accessible and individualized to the patients. Transition care only became important since the 1980s, since before many patients with severe chronic disease even didn't grow up to an age of more than 20 years. But we know now that by the improved therapeutic possibilities, more than 90% of the children with chronic diseases have a life expectancy of more than 20 years old. Now, specifically for the transition of patients with inherited metabolic diseases, these are special cases. Since inherited metabolic diseases by themselves are rare, but by definition in a frequency of less than 1 to 2,500, 1 to 5,000 living births, but due to the enormous heterogeneous metabolic diseases, there are plenty of patients, and it is estimated that 6 to 7% of the population of children with chronic diseases have inborn errors of metabolism. What is especially difficult in these diseases is the large heterogeneous spectrum of diseases, where some have life-threatening disease in early childhood, but have a stable disease and can do almost everything in their adulthood, compared to other patients where we see that they do relatively well, but have progressively physical and mental debilitating conditions when they grow older. So there is a diverse heterogeneity in the evolution of these diseases, which also means that it can be a simple condition where only a physician with a dietitian, a psychologist manages the patient, to diseases requiring a large multidisciplinary care. And the problem that we encounter often is that transition has been studied in many chronic diseases like in cystic fibrosis, type 1 diabetes, chronic rheumatologic diseases, but due to their rare nature, studies in adolescents and young adults with inherited metabolic diseases are scarce. What we want to do this afternoon is giving you an overview of how we made up the protocol of the transition care in the University Hospital of Antwerp. And then secondly, I will give a presentation on the difficulties that we encounter in adult care with those patients. First, I give the word to Elien, which is the coordinator. She's a psychologist and she's coordinator of the transition team in our center. Elien.
Okay, thank you. As Dr. Verhagen has said, my name is Elien REATS, and I'm psychologist. I work here at the Center of Inherited Metabolic Diseases in Antwerp. Today, I will talk about the process of transition and the program that we have created here to facilitate continuity of care when our patients transition from pediatric to adult healthcare. So transitions occur throughout life and are faced by all young people as they progress from childhood through puberty and adolescence to adulthood. And our patients, because they are facing a chronic illness, they are experiencing extra transitions. As a result of advances in medical care, the proportion of children who now survive chronic childhood illness, such as metabolic diseases, continues to increase. And it's a topic that we have noticed is very sensitive with families. The transition from pediatric to adult care occurs in a time period where so many regular transitions are already being faced. And this one especially is big for patients. We are facing many changes within this transition process. So it's a topic that has to be handled with care to prevent difficulties. So as a bit of a background information, okay, I will go through some of the psychological tasks of an adolescent. So adolescence is a period of different developments with a lot of physical, with a lot of cognitive and social changes that occur during the transition from childhood to adulthood. And adolescents have important psychological tasks to go through. So the extent to which someone has developed these skills determines their capacity to participate in an adult healthcare system. And adult physicians need to be mindful of the developmental stages of the young person to provide appropriate care. So the first task is the ability of abstract thinking that is developing during this time period, including the potential to consider future time perspective and to consider the consequences of actions. And secondly, peer relationships become more important during adolescence. For example, the potential to consider it other people's point of view. Friendships will depend less on shared interests and more on shared ideas or feelings. Also developing a sense of identity and separating from the birth family is an important task, as well as sexual identity and gender. Those are also included here. Then there's also building educational and social skills in obtaining employment. That is very important. And adolescence is also a time of re-establishing relationships with family due to increased independence and autonomy. And their task also includes establishing a sexual identity and developing the skills for romantic relationships. Okay. So this is an illustration of how the transition from child-centered to adult health care is managed here in CEMA Antwerp. So we have a pediatric metabolic unit with a multidisciplinary team that includes a dietitian, a pediatrician who is expert in metabolic diseases, that includes a psychologist who is also transition coordinator. And as you can see, they form one team together with the patient and his family. And in our case, patients do not have to transfer to a different hospital. So our team remains the same team with the same faces, only the adult physician who is expert in metabolic diseases is joining our team. So patients do not have to switch centers or hospitals, and this facilitates continuity. Nevertheless, there's still a lot of other interventions to consider to guarantee continuity. And the concept of transferring young people's clinical care from a pediatric to an adult healthcare setting, it's not new. For several decades, many adult hospitals have been successfully managing patients transferred from pediatric institutions. However, most of these hospitals have not been actively involved in planning the transfer of patients from pediatric services. So how transition is managed and planned between pediatric and adult healthcare settings, it plays a very important role in the engagement of the patient in the new healthcare system. And transition to adult healthcare has to be planned or may result in patients being lost in transition, which includes problems as dropout, adherence problems, medical complications, psychological problems, and daily life problems. So we have set up our own transition program for effective transition that I will now illustrate. So we have 3 phases. The first one is the preparation phase. Then there's the actual transition phase, and there is also an evaluation phase. So first, the preparation phase. As the preparation begins, we have an information brochure, and this brochure, we will send this to patients that are starting that transition process that year. We will also include this brochure in a map that patients receive when the diagnosis is established, so that patients are aware that this transition process is taking place at a certain point in their lives. There's a few key interventions that we found in literature that are important to obtain an effective transition process. The first one is a joint consultation with both a pediatrician and the new adult physician that will follow the patient into adulthood. It's called a transition consultation, and these consultations also include the presence of a transition coordinator and a dietitian. And to obtain continuity, it's important that the new physician is introduced to the patient records, and seeing the new physician's face to face is also an important way to build trust and increase patient satisfaction. Then there's also the importance of a transition coordinator, as it's written, who coordinates the whole process. In our team, that is me, I'm a psychologist, and I take care of the planning of the whole transition process. Another key intervention is continuity between the pediatric setting and the adult setting. So a joint policy that we know reduces the risk of problems and dropout. Then we also arrange transition meetings that are multidisciplinary to discuss patients and possible problems. And then there's also the information brochure that's important that I already showed. And another key intervention is to increase independence and prepare adolescents for transition. Literature says starting at the age of 12, but we start a little bit later. So in our center, all of this is written down in a transition protocol that we apply for every patient, of course, in a flexible way. Every patient still has an individual program. Okay. So the preparation process includes a few important tasks that the physicians, dietitians, and psychologists need to discuss with the patient. So first off, the patient needs to understand his condition and current health status. He needs to be aware of medical records, of diagnosis information, and so on. He looks after his medication. He's able to repeat prescriptions, and he also needs to know how his diet works. Then self-advocacy is about speaking up. Speaking up for yourself, being able to ask questions when needed, and to understand your right to confidentiality. And then self-management is about seeing a consultant and other health workers by self. It's keeping a calendar of appointments, knowing health emergency telephone numbers, being able to tell others about your condition in situations where it's needed. Then health and lifestyle includes general health topics such as exercising, understanding the effects of drugs, general health recommendations, sexual health topics, and the same goes for other topics: school, career, future, leisure, mental health. Those are more general topics. Then last but not least, it's important to prepare the adolescent on what transition means. Practical things such as taking an orientation visit to the adult setting if that is necessary. Okay. Another important topic that we prepare patients for is the difference between both settings, so the pediatric and the adult care. So pediatric care tends to be more family-centered, where adult care tends to be more individual-based. Then also pediatric care is more generalistic. There's a more interdisciplinary team approach, where in adult care there's a more specialist orientation. So pediatric care may be more informal, where adult care sometimes is more formal or direct. And then there's also a difference in focus. Pediatric care is there's more a holistic focus with attention for development, for learning issues, school and social functioning. Where in adult care there's a more disease-oriented focus, where treatment, complications, compliance are very important topics. In pediatric care, patient is seen as more vulnerable or dependent, and in adult care, patients are seen as co-responsible and self-reliant. So it's important to prepare patients for these kind of shifts, so they will be able to cope better with this new adult care system. This is the schedule that we maintain, and first I will discuss the preparation phase. So we start at 16 years old, and patients will be invited for a first transition consultation, and we will repeat this at 18 years old. And during these appointments, patients will fill out a questionnaire that will help us understand how prepared a patient is for transition and what topics need some extra advice and help. And there is also a psychological consult provided, where psychologists will create a transition program to suit the patient. And in between those transition consultations, the consultations are just regular with the pediatrician, but there is also a psychological consult to keep an eye on the individual transition program that the psychologist has developed with the patient on the first transition consultation. So this is an example of the questionnaire that is being used. It's the Ready, Steady, Go that we use as a questionnaire. And this is the Dutch version that we use. And the next one is the English version to give an impression of what is being asked from patients. This questionnaire is an instrument that will help us provide an individual care system that suits the patient. So not every patient has the same struggles or questions. Some patients will need more dietary follow-up, others will need more psychological help, others will need little care or help. So this really helps us focus on the right topics that are needed to prepare an adolescent on transitioning from pediatric to adult healthcare. Then there's the transition phase. So at this point, we hope that we were able to guide patients and that our patients are prepared for the transition phase. And this happens at 20 years old. Then we will organize a third and last consultation with both physicians. Then there's also an evaluation phase in the end. And from there on, so patients will be consulted by their new physician, and transition coordinator will evaluate the whole process by asking patients to also fill in a satisfaction survey. So this is the transfer experiences scale. It's from On Your Own Feet organization, and it's a survey that is specific for transition and can be used for a broad spectrum of diseases. This is just a small part of the survey to give an impression on the questions that are being asked for patients. So the last part, future challenges. There's a lot of future challenges, but I want to focus on one future challenge in particular that is definitely something important at this point, and it's patients with intellectual disability or physical disabilities or limited self-reliance, which is very common in metabolic care. And the question is how to include these patients in this whole transition process. In literature, transition focuses a lot on preparing patients to be independent, to be self-reliant. There's a big focus on self-management, and these are often impossible requirements for patients with severe disabilities. And family care remains very important for a lot of our patients. Including parents and consultations can remain important, providing the possibility of co-sleeping during a hospitalization, doctors that need to communicate with parents rather than the patient in some cases. So this is a very important topic that is missing in current literature and an area of concern. Make sure that there is continuity of family-centered care in the adult healthcare system. So this was my part. Thank you for your attention, and we will proceed with Dr. Verhaegen's presentation.
Yes, good afternoon again. So I will take now the opportunity to reflect a little bit on the opportunities and the practical problems that we see in adult care. And I'm going to have a thread through the presentation with 3 patients. Lydia is at this moment 20 years old. She is a patient with galactosemia, was always well controlled and is very compliant with her therapy. She's got autism spectrum disorder, and she was transitioned at the age of 25. With no big problems that were encountered at that moment. She, at that moment, was living with her parents, who always joined her at the consultation, even on the adult ward. But at the moment, at 27, she decided to go to live on her own together with her boyfriend. Notable is also to say that she works as an administrator in a police office, and we will talk about her later on. Second patient is Jeff, a male patient. For the sake of privacy, I did not mention all the diagnoses of the patients, but who is spastic quadriplegic. His visual disturbance, he cannot eat himself, so he has got his tube feeded, and he's got therapy-resistant epilepsy. His acute medical problems at the moment of transition were epilepsy and recurrent pulmonary infections. He was transitioned at the age of 21 and is living with his parents at home, who are the primary caregivers to this patient. And then third, there is this young woman with MPS 6. She's a patient with short stature, as most of these patients. She's got serious orthopedic problems, movement disorder by these orthopedic problems, and by cervical medullar compression. She's got hepatomegaly. She's bad hearing. She's got visual disturbances, severe OSA. She's got a low IQ of, at this moment, as an adult, she has an age of a child of approximately 12 years old, and she's got severe restrictive and obstructive lung disease. Now, when we talk about transition, of course, when we look at it from the adult point of view, the adolescent or young adult that we will go to see as a patient is always in the center of our work. But we've got to realize that going through the transition is a process of complete dependency on others, like in the children, especially children with chronic diseases, to gain an independent life as much as possible. And as Elien already pointed out, there are a lot of fears in the adolescent, in the parents and family about how this transition is going to happen, especially since the moment of transitioning is also a moment in which other very important decisions about the future of a child or adolescent have to be taken, like, is he going to continue to go to school and study? Is he going to work? What is he going to do? These are, even for healthy adolescents, already very difficult things to take, decisions to take. So especially when this is happening together with a chronic disease, it makes it even more difficult and worrisome. Parents are afraid of losing the control over the disease of their child, and will lack the contact with a pediatric team that they have for 20 or 25 years, and in many times they have seen the pediatrician so many and the team so many times that it is almost becoming their family. And another thing that we've got to face, and which can be very important, is that also at the moment that patients transit from pediatric care to adult care, is that the organization of healthcare facilities is completely different. Social security can be a big problem to encounter, and some of the reimbursement rules are different. When we talk about the care models from pediatric care to adult care, I'm not going into the details because this was already pointed out by Elien, but why I put an arrow is that because transition really is a transition and not a transfer of the patient. Where pediatric care, with all its characteristics as are mentioned here, are mostly seen as warm and enjoying for the patient and his families. In adult care, there is more coolness, and we are more I don't know how to call it in English, but more, well, it's not so important. But what is important is that we try to continue the care with patient safety and at this in particular vulnerable time in the maturation of our patients. Now, who of the adult care physicians will take care about patients with an inherited metabolic disease? Because as you see here, and I think I even forgot some, only geriatric care at this moment, maybe they will in the future, but only geriatric care is not involved in taking care of inherited metabolic diseases. So already one first decision that has to be taken in adult care is to make a person or a team that will engage in learning to know these inherited diseases. And then secondary, when we look in one patient, even then here in red are all the physicians that are engaged in the care of these patients with MPS. So that means that many different subspecialties of adult medicine, as well in internal medicine, but also surgeons, transplant team, etc., are involved. And someone has to be taking the lead, but of course, multidisciplinary care is very, very important. And one of the problems that we are encountered with is that in adult care, there is inadequate formal training in inherited metabolic diseases, which still at this moment are considered mostly as pediatric diseases. And also in adult care, there is not a history of real multidisciplinary care. We've got multidisciplinary care teams in small teams, like for example, in type 1 diabetes, where we work with nurses, with dietitians and psychologists. But in inherited metabolic diseases, this goes much further. We've got a basic team, and then there's all the other caregivers which have to work together, and which mostly in adult care clinics is much harder to organize than in most pediatric care clinics. One of the things that can make it also difficult for the adult caregiver is that this is very time consuming. Normally in my regular patients, I see one patient in about 15 minutes, a diabetic patient. Well, in my patients with inherited metabolic diseases, I count on half an hour to 3/4 of an hour. So that means that I've got to spend double to triple of time with them than with the regular patients. And this can cause a harm or a barrier for other adult care physicians to care about these patients. And in adult care, we've got lack of administrative support, which also can be a barrier. Last, when even the adult care physicians would have formal training in these inherited metabolic diseases, even then it is not ready, because then we've got to train also our dietitians, our nurses, and the people, for example, of the day clinic for these very rare and specific diseases, and also specific therapies. Barriers that we encounter with the patients themselves is that the focus in adult care is mostly on self-management of the disease. This, of course, implies that the patient knows his disease, his or her disease, knows the treatment plan and the prognosis. Because if you are not aware of what your disease is about, what if you do well or bad, what will be the consequences of it, then it is very hard to self-management on that disease. So we see that during transition of care, the education has got to be given to the patient themselves, because in many cases, parents are taught when the patients were diagnosed in the beginning and the therapy was started in many of the inherited metabolic diseases as babies or very young children, but it is not always so that the patient themselves are re-educated during this process. So this is very important that we first do this and also try to have an idea of what the patient knows about this disease and about the evolution. And of course, this can contrast with the potential of patients with, for example, mentally illness, psychiatric illness, or other hearing or visual problems, that can contrast with the possibility of self-managing their disease. So in those cases, like in the two patients that I mentioned, involvement of the parents and the other family caregivers, even in adult care, is very, very important. But we've got to take care that in other cases where the patient is possible of having self-management and of taking their own decisions, that we counter overprotective parents, which can interfere with the self-management, because the adolescent and young adult will revolt against this. And in all these issues, the supportive team of psychologists is very important. They can assess the cognitive function of the patient. They can assess where the patient is in the accepting of their disease and in knowing the skills and practice skills to self-care, and can follow up and adequately train patients in coping skills. And of course, also necessary is that the patient is given a voice to enable communication as the person themselves in adult care. So this means that transition should focus on the development level and not only on chronological age. Back to our patients, where I will put a little bit stress on the specific needs of these patients. Jeff is the quadriplegic patient, and he, at a certain moment, needed to be hospitalized for pneumonia in acute care. There we encountered many problems, like first, there was serious emotional distress and discomfort when his parents were not near to him. So that means that parent has to stay with him. We first tried to do that in a room for one person, but then the parents needed to sleep on a little stretcher. So at that moment, we decided to move him to a room for two persons, where one person was the parent and the other one was Jeff. So this is a practical problem, maybe very stupid, but which is not always so easy to regulate. His body weight was 38 kilograms and he was tube feeded. Can we adult dose him for the medications? No. So that means that we've got to train the nurses that in these cases we need to adapt the doses to the needing of the patient. And another problem is that Jeff is rather noisy. He snores, and instead of speaking, he produces a lot of sounds to express himself. That means that other patients in our acute care wards were not always that happy that he was lying there, and that with respect to his integrity and his to his integrity, we needed to inform other patients what was the problem. So progressive disease or acute deterioration, like here in the problem of Jeff, can indeed impede transition to adult care, and especially in patients with progressive disease. It can be so that the moment that they have deterioration is a bad moment of transition. But of course, this is not always easy to precede or preview from advance. Patients often remain stable for a long time, and just at the moment that they go through transition, go to a bad moment. Or in the other way, it can be so that you try to postpone the transition phase, but that the patient indeed, despite all his medical problems, has rather stable disease. And for example, in our patient with MPS, she comes to the clinic despite all her problems. She comes to the clinic by herself and does all her consultations on an individual basis. Another problem that we are confronted with in adults and especially in internal medicine is that we've got inadequate formal training in physical and intellectual disabilities and all the concerns that about. Also, during the hospitalizations, there can be special needs that we've got to encounter, like, for example, the dietary needs of patients with inherited metabolic diseases. When the pediatric wards and the adult care is in the same hospital, even when they are not exactly in the same building, then the dietitians are near to adapt the feeding of the regular hospital food. But for example, in cases where there is no pediatric ward in the neighborhood, then this can be, for example, a problem. On the other side, having a patient hospitalized in the clinic can be an opportunity to re-educate the young adults themselves to the meal planning. Problems with handling mentally and physically high demanding patients, patients with psychiatric disorders, needs extra training for the nursing staff, and also in this, the support of psychologists and the social workers is really essential to bring this to a good end. Nurses of, for example, the day clinic and the hospitalization ward will also need training in inherited metabolic diseases and the specific therapies like enzyme replacement therapy that is needed in these rare diseases. So again, we are going to our patient, Lydia, 28. So at 27, she wanted to live on her own with her boyfriend. He was a little bit pushing on that, but who wasn't giving any support on her diet or keeping up the compliance, meaning that she was less compliant at that moment and deteriorated in her liver function, but also there was serious mentally deterioration with concentration disturbances, motoric agitation, and more autistic behavior. At that moment, this was especially a problem because she was incapable of performing her tasks as an administrator in the police office, and we demanded partial invalidity. We are 2 years later now, and even at this moment, we don't have a final answer because of the specific social rules here in Belgium. So that is another problem that we are encountering in adult medical care with patients with serious and debilitating chronic diseases, not only the inherited metabolic diseases, but all chronic diseases. That is that financial support can be hazardous. As long as the patients still live at home, in the families where children with a chronic disease live, mostly social benefits are more easy to get than once they are older than 25 years old. And also having the chronic disease itself can impede educational achievements, for example, because children due to the disease cannot go to school at a regular basis, or because the disease itself is impeding further education, which of course will have an impact on their working capacities and directly will have an impact on their earning. Diseases itself can be costly, depending upon the social system in the country. Dietary measurements, dietary supplements, etc. All the medical costs of the caring physicians, diseases can be at the end very costly being. And I don't know how it is in other countries, but in Belgium, social security is provided by the insurance of the parents until the young adult is 25 years old. And afterwards, they will or have to be taking care of themselves to be insured, except in those cases where prolonged dependence is made and there an administrator is indicated with all the problems that are encountered with that. So also for these things, well-trained social workers and a cooperation with social self-care organizations are essential. Although there are a lot of barriers, we also have to see the opportunities to be taken into account. So close communication between the pediatric and the adult healthcare teams is especially very, very important. And here in the UZA, we do approximately monthly staff meetings involving all members of the pediatric and the adult team. And I think it is very important to transfer the patient file. In our case, we do that, in fact, a little bit during the staff meetings, and then finally at the moment that the patient goes into transition. This can also be done in other ways, but what is important is that not only the medical history is transferred, but also that we as adults get to know about the social history of the patients. How was his adherence in the past? What are situations that distress this patient? How is the family condition of this patient? But because even in adults, this is very, very important when we have to take care about adherence and self-management. And organizing shared ambulatory consultation with the patient, as is organized here, is also helpful so that we get to know each other in a timely manner. Timely preparation has already been pointed out by Elien. So we start at the age of 16, and gradual transition and the period of joint care is very important. If possible and feasible, the patient and his family should make the decision on the moment of transition. However, it is not always possible. And meeting providers alone during the consultation is also seen as a useful intervention, so that patients, even when part of the consultation is together with their parents, that a part of the consultation they can express their own doubts and their own concerns, and this can encourage self-efficacy and self-reliance in these adolescents. For the adult care specialist, formerly general internal medicine took care of the inherited metabolic diseases, but this shifted a few years ago to endocrinology for practical reasons. One other plus is that we are knowing that we are engaged in getting knowing metabolism, and also are familiar with transition care in type 1 diabetes patients, obesity in the youth, and rare endocrine diseases manifesting in childhood. So that is possibly a plus. And also we are familiar with the multidisciplinary approach, working together with dietitians, nurses, educators, and psychologists. In the UZA, we chose the other members of the team, the psychiatrist, the psychologists, the dietitians, and the social workers, to remain the same as in the pediatric team. So that means that only I, as an adult physician, come into the care of the patient, but the other phases remain the same. So that means that patients and parents are familiar with all the other members of the team that are all well trained in inherited metabolic diseases, which makes within the CEMA an affordable and accessible care. However, in some cases, it can be difficult that the team remains the same. For example, when the patient is hospitalized, then the pediatric dietitian and pediatric psychologist has to be involved in this adult care. And in some patients, I didn't have this experience yet with inherited metabolic diseases, but for example, in type 1 diabetes, some patients say that it is a good moment of transition and that they don't have to go back to the old team, especially in cases where they see this as a new start and their adherence was not so good in the past. That can, of course, make some friction between the therapeutic team and the patient. And in that case, it can be a plus that the team is new also. And then another problem that we encounter with is the distance between the wards, which sometimes causes practical problems with the organization. The needs to optimize care of adults with adult care with inherited metabolic diseases in adult care setting is that formal training of internal medicine in inherited metabolic diseases, including the diagnostic procedures, at this moment is not in Belgium, is not very good. And the same for the adult dietitians, psychologists, and social workers. So this should be encouraged in the basic program of the training of these persons. Multidisciplinarity should be encouraged between the specialists themselves and with other departments, which is not always so easy to organize. And then structural adaptations, for example, the possibility for parent-child hospitalization, even in adult care, is necessary. And then finally, what often is missing, and what I also missed in general literature about transition care, is that there is a need for close collaboration with the general practitioners and the first-line social workers that most often see the patient in their basic home living. So transition is moving from a big part in pediatric care to adult care. It is an evolution and not a moment, where it is important to have a transition plan and a transition coordinator to make this as easy and as smooth as possible. I hope I gave you some insights about the difficulties we encounter in adult care and how we try to move forward with it. But we still have much to learn about best practice in transition of rare diseases, and more emphasis should be pointed on research in this field and exchanging experience. And again, I grant my thankfulness for giving us the opportunity to share our experience with you all. Thank you.